have Chris Matthews playing hardball with Dr. Tony Fauci. I have known, admired, and worked with both of these two leaders for more than 2 decades, so let me give you an inside scoop on them. If you perform a Google search for Global Health Hero, up pops the picture of Dr. Tony Fauci, director of the National Institute of Allergies and Infectious Diseases at the National Institutes of Health. Since his appointment as NIAID director 25 years ago, Dr. Fauci has worked tirelessly to increase knowledge about the causes, treatment, and prevention of the disease. He's been a pioneer in unraveling the mysteries of the HIV virus and is among the most cited scientists in the field. Some of my first years working at NIH 25 years ago were of that early war against AIDS, working to marshal and mobilize scientific skills and resources across institutes to battle this mysterious emerging infectious disease threat. Tony Fauci was in the lead then, and he was in the lead now. In recognition of his pioneering and landmark contributions to the fight against AIDS and other immune-mediated diseases, Dr. Fauci has received numerous awards, including the National Medal of Science, the Mary Lasker Award, 34 honorary doctorates, and the Presidential Medal of Freedom. Please welcome Dr. Tony Fauci. A media giant and American original, Chris Matthews blends a career of public service and communication with a deep knowledge and love of politics and history. After service in the Peace Corps in Africa, Chris worked as a speechwriter for President Jimmy Carter, and then as a top aide for legendary Speaker of the House, Tip O'Neill. In the late 1980s, Chris switched to full-time journalism. In 1997, he launched Hardball, now on MSNBC, which was the title of his best-selling handbook on real-life politics, published in 1988. He has been on the air every single weekday night since. In 2002, he also added hosting a Sunday morning talk show to his media megapoly. Chris is the author of 6 best-selling books, and his new one, Jack Kennedy, Elusive Hero, is due for release in November of this year. And I've seen the galleys, and it is fantastic. Brings to bear everything Chris has learned through a lifetime of watching American politics in action to illuminate the character development of this beloved president. Chris Matthews' work is animated by his love of our country and its history and its hopes, by his faith, by his beautiful family, and by his friendships. So it gives me great pleasure to introduce my treasured friend for more than 25 years, the incomparable, the mesmerizing Chris Matthews, for a conversation with Dr. Fauci.
If I were normal, I'd say that embarrasses me. Thank you all. This is a historic occasion in an historic room. For the young people here, this is where the Army McCarthy hearings were held in 1954. You can go watch them in probably any Google search will bring you back to the history of this room, since we're talking about history. It's also, of course, the Watergate hearing room in 1973. This is where the story really broke up. People in this town, we call it this town, Washington, were mesmerized more by Watergate than they were by this stupid debate over the debt ceiling. There was really a good story with fascinating personalities. So this room today comes alive over a history we'd like to, like McCarthyism and like Watergate, we certainly would like to see go into the ash can of history, that's AIDS. I once read I'm a movie buff, of course, and people know that about me, and one of my favorite movie lines is from a cult film, Pretty Poison, where there's Tony Perkins, the actor, said that people only really believe what they discover for themselves. And that is absolutely true. Unless you discover something in a personal way, it's just an abstraction to you. Like a lot of us here at my age, we lost friends. I think their names are public, David Pickford and Herb Denton and John Robinson, the Globe, who were in public life, who were journalists, and you probably shouldn't write their names down if you're in journalism. You never know how stories were covered at the time. So they all died of this disease, and sometimes quietly, through embarrassment. It was all real people, real faces come alive to me. I was in the Peace Corps in Africa, in Swaziland. I was in Swaziland 1. That's how we call ourselves in the Peace Corps, the first one in. in the 60s and 68. And that country's now suffering, as Dr. Fauci knows, we'll talk about that in a minute, with PEPFAR at about a 26% rate. In fact, all the young people are really under terrific assault by that disease. The people that are going to make that country are not making it. That is one of the horrendous facts about AIDS, that it attacks people in their productive years when they could be building a country and they're just dying. So that's something I care about. I want to thank the two people who are here for us, Susan Blumenthal, who is not only, you know, sometimes you hear that liberals aren't really liberals in real life. They're not really liberals, they're a little snooty. This is a real liberal here in real life, a real liberal. It's not just the theory, it's the humanity of her as a family friend, looking out after our friends, and she loves our kids, and she's rooted for them and made them what they are. She's great. She's a great champion in the AIDS fight, but also in day-to-day life. And Tony Fauci, I don't know many famous, really great people, but he's one of them. And he went to my college, or I went to his college. And someday I'll catch up to his number of honorary degrees. I don't think I will, though. It's great to be here. Let's get started here. AIDS, 1981, it began to be getting incidental illnesses. People were dying, gay people in many cases here in the United States. How are we doing?
Well, for 30 years that have transpired from those first days, we're doing extraordinarily well with regard to the tools that we have to fight the epidemic. We have an enormous challenge, both scientifically for things like a vaccine and a cure, but probably even more important for today's agenda is the challenge of being able to take the science and use that to implement what will have immediate beneficial effect for people throughout the world. So the early years, I remember very well, because they were some of the darkest years of my life, where you had nothing. You didn't even know you were dealing with a virus. You just had people coming in and dying. And as a physician, and I know so many people shared that, that was devastating to the patient, to the physician, to the healthcare provider. And then over a period of several years, now 30 years, we got an accumulation of scientific data, of scientific tools that have put us in a position now of being able to transform the lives of HIV-infected individuals. Just very briefly, for example, in the clinic that I was in this morning, which I've been in every day practically for the last 30 years, if someone came in the summer or the fall of 1981 with this new disease, they usually had advanced disease, and their median survival was about 6 to 7 months. That means 50% of them would be dead within that time. Today, if the same 20-some-odd-year-old comes into the clinic with newly discovered HIV infection, and you put them on the array of drugs that the scientific process has given us, you can predict to that person that if they take their drugs, that they would live an additional 50 years. That's the good news. The sobering news is, as Susan said, only less than 42% of the people throughout the world who would benefit from that therapy actually have access to it. That's the real problem.
So you take a poor part of the world like Swaziland, which is in southern Africa, between Mozambique and South Africa. You take a little country like that, and if they had the antiviral, then people who would be vulnerable to getting HIV wouldn't get it, probably.
Well, if you...
Just to get this latest, that Kenneth was talking about, the latest developments, if they were applied out in the worst case areas, would it be really killing AIDS in effect?
Well, yes, but the real challenge is the real world, on the ground implementation of identifying infected people, getting the drug to them, making sure within the context of the customs and the traditions in that country, whether they'll actually take their medication, preventing infection in others. But the scientific answer to your question, Chris, that hypothetically, if you went into a country and were able to identify every infected person and treat that person and get their viral load to below detectable level, you would decrease the likelihood of that person infecting anybody else by 96 to 98%.
Do these leaders of the world leaders that have access to the internet, do they all know this? Is that even known at the time? I mean, seriously. Now, this was a problem in South Africa recently. There was real resistance there. do people in the world, the leaders, know this? The health ministers of African countries, for example, do they know this?
Yeah, they know this now. South Africa was a bit of an aberration, but not a total aberration.
You mean
years
Thabo
ago.
Mbeki?
Yeah, in the idea of not even appreciating or admitting that HIV caused AIDS. That's behind us right now. South Africa has really now becoming almost the leader in the implementation of these programs. But when you talk about world leaders, that was one of the real important parts about the meeting in Rome just a week ago, last week, is that it became crystal clear that we know we have implementation challenges, but don't argue that we don't have the tools to be able to do that implementation. Because people somehow or other, consciously or subconsciously, don't want to face the challenge of what we need to do. It's going to be extraordinarily resource intensive. This is going to be very, very expensive. But one thing we know for sure, you're either going to pay now or you're going to pay more later.
Right.
That's the issue.
Well, what's the story on PEPFAR funding right now?
Well, PEPFAR has done a spectacular job along with the Global Fund and other funders, NGOs, in getting treatment, life-saving treatment, to now about 6.6, 6.8 million people in low and middle income countries. So they're doing the job, they're saving lives. The challenge is that there are right now at least 9 million people who would benefit from therapy who don't have access to therapy.
It's interesting that George W. Bush was the president who led us into that area of PEPFAR. What inspired him? What triggered his, he's a conservative.
Right.
What led him into this field to do this?
Well, I had the privilege of being one of the people who was involved in designing the PEPFAR program, and I can tell you in my discussions with him and with his staff, Josh Bolton and others, he said that he felt a moral responsibility as the leader of a rich nation to alleviate the suffering where possible of people in the developing world. And I had spoken, and others had spoken to him about the opportunities one has in the developing world with HIV/AIDS. So he sent me and a couple of others to Africa and said, go and see if this is feasible. And to their great credit, the African physicians who had very little resources were proving that if you put the drug in their hand, they could get it to the people, and the people can actually do it every day. And when I came back and presented that to him and his staff, they said, well, design a program that would have the most bang for the buck, and let's see if we could do a game changer. So it was all him. It really was.
Has President Obama, be critical now, has President Obama carried on the fight as well as he could?
I think as well as he could, yes. The problem that the president is facing is an extraordinary constraint of resources. Here we are in Washington with the debates that are going on about cutting everything. If he had the resources, would he do it? I'm absolutely convinced. He has put the PEPFAR program, our contribution to the Global Fund, under the larger umbrella of a global health initiative, which would be not only HIV, malaria, tuberculosis, but maternal health, child health, nutrition, et cetera.
Is that good?
That's good. He's deeply committed. The problem is we don't have the resources.
What about the fight that's going on? People here are interested, they're advocates and activists. Is there a fight that's going on among the committees now for the FY 2012 budget?
Well, I wouldn't say fight. I think the problem is that if you look at one side realizes the reality of not being able to get a big increase in the budget, the other side wants to cut it dramatically. So at the end of the day, even with a compromise, it's going to be less than what we need.
But even as a civil servant, can you say objectively that it's a bad investment decision to cut it?
Oh, I've said that publicly 1,000 times. I'll say it publicly now. It's not a good idea, not only because of, I believe, we as a nation that historically has cared about others as well as people within our own country, that we have, somewhat of a moral obligation to address the ills of the world. Obviously, people will come back at me and say, well, we have a lot of constraints and resources. That doesn't erase the fact that if we had the resources or if we could get more, we should do it, because it's the right thing to do.
Let's talk about the private sector, the NGOs. Bill Clinton, I'm so impressed. My son Michael worked for him in Rwanda for 5 months. making sure that the drugs get to the people, not go on the European black market, like they were going. How's that doing? How's the private sector doing?
Well, the private sector is doing very, very well. For example, the Bill and Melinda Gates Foundation, Médecins Sans Frontières, the Clinton Foundation has done a phenomenal job, less in pouring hundreds of millions of dollars than being a phenomenal facilitator in bringing groups together, getting the prices of drugs negotiated down. So, I mean, that
with the promise it won't be stolen.
Right, exactly. I mean, that phenomenal talent that President Clinton had and exhibited when he was our president, now you put him out in the private sector, he's still as great as he always was.
Let's talk about priorities, because you're talking about the budget crunch and the debt fight and all that stuff. And at the real level, it affects whether things get done now or they don't get done. So if you have to look at treatment here, research here, treatment abroad, how do you array the triage? How do you handle it? Triage.
Chris, that is the question that everyone is struggling with, because you can say that if we had unlimited resources, you wouldn't need to triage. You could do whatever you want. So one of the things that was discussed with great intensity in Rome and beyond Rome before and after is, given the limited amount of resources, what is the best way to spend money within a particular country or region, within the particular conditions in that country, within the particular risk in that country. So if you have a situation in country X where you could implement very easily circumcision, we know it works. If you have situations with mother-to-child transmission, if you have situations where you could actually get people into therapy, you would, I wouldn't say triage, you would prioritize what is the most cost-effective way to spend the money you have. And a number of organizations, including PEPFAR, the CDC and other organizations, are doing what's called implementation research, where you actually figure out from a research standpoint, is this an effective way to prevent or treat infection in this country versus that country? And you wouldn't think it was a research question, but it actually is. It's the research on how best to implement the program.
Let's talk about it. I was over with my wife last year in Mozambique, talking to young Peace Corps. We try to do it wherever we go, meet Peace Corps volunteers. And they're working on AIDS. Now, it is so tricky, as you know, in the cultural setting. You might have men who are very upset about your arrival as a worker involved in this field, that it may be in your interest not to even say what you're doing. Now, they have to go into a community when they're assigned by Peace Corps to go in and say, I'm here as a health advisor. They never mention AIDS. Then they have to go and they have to say, I'm here, and the mothers, who are scared of their husbands in some cases, have to bring the kids in and say, I'm bringing my kids in to get treated. And then they somehow manage to get checked out themselves. Do you realize how circuitous this route is?
It's very.
So talk about that when you talk about having to do what you call research, and I think people are stunned by the fact of how circuitous a route you have to follow to save people's lives.
Exactly, and that sometimes generates research questions. So the scenario that you and Kathleen and your family experience is exactly what goes on. So you can't just go in and say, okay, we have a treatment, let's test everybody and treat them. You have a husband or a sexual partner who's a male who has no interest in being tested or treated, and it's likely that his wife is either already infected because he infected her, or she's at risk of getting infected. So you can't just go in and say, we are here and we're going to fix the problem. That's why we do things like develop topical microbicides for women, where you can actually have a gel, which when it's permeated with an antiretroviral, can actually prevent infection in the woman without the male sexual partner having a clue of what's going on.
Wow.
So that's the way.
Have you been able to permeate that around? Have you been, like in South Africa, Swaziland, those countries?
The first studies have indicated some interesting data. A, it works. B, the obvious, it works only when you use it. So if you look at individuals who are using it, the efficacy is very high. If you look at the whole study and you find out, gee, you know, we only had a 39% efficacy. What happened there? And then you go back and you ask people. It was the same thing with the study that was mentioned just a few minutes ago, the pre-exposure prophylaxis study. So if you can give a pill to someone, in this study it was men who have sex with men, and you could prevent acquiring infection if you are uninfected.
Yeah.
So the efficacy of the whole study was 44%. If you actually asked people and say, did you actually take the pill?
I know.
And they said yes, the efficacy becomes 70-some-odd%. And we say, under your breath, I don't really believe you.
I know.
I'm going to draw your blood and determine if you actually took the drug. If you actually took the drug, the efficacy is 90+%.
Yeah, you know that's true of people watching TV shows too.
Yeah.
They say they watch Seinfeld every week. It's, you know, a third of the time, two-thirds of the time, but it feels like every week, you know.
Yeah.
But so I don't want to make it culturally, you know, prejudicial here. The fact is, most cultures, it's hard to get a straight answer out of people.
And that's why the challenge now that we have the scientific proof that it works is how do you get it to work in the population that you're dealing with? And it's different. I mean, it's amazing if you break down, for example, the pre-exposure prophylaxis data, even in the United States, the difference in adherence to the regimen, whether you had a secondary and tertiary education versus a primary education, whether you were less than 25 or older than 25, whether you were African American or white, whether you were rich or poor. Yeah. It was amazing. Amazing.
Well, it works, obviously, in public education. People don't, how many people here smoke cigarettes? Come on, hardly any, right?
Right.
This crowd here, what, 10%?
Right.
The most? No love, no glove, no love.
Right.
These kinds of signs up in third world, do they work? Big posters about AIDS prevention. I see them when I go around. Do they work?
You know, in some situations they do, but what probably works better than targeting the broad population is to get your prevention modalities to go after people who are at the highest risk group. Obviously, you have to have a general approach, but you really need to intensify in the target risk populations by someone who they respect and understand.
Well, let's get back to this country. You know, we all learned about the problems, the bathhouse, the whole thing that was going on, the crazy living that was going on in the time of this thing came out, and then people began to adjust their behavior, and they survived. And where we stand right now in terms of risk behavior right now? Risky behavior.
You know, it depends.
Are they getting complacent again? Or
yes. The answer is yes. It's a complicated issue, but the fundamental answer to your question is yes. Back in those dark days, where you had this unfettered bathhouse type culture.
Right.
You go to the Castro in San Francisco,
Sure.
or you go to the Village in New York, and you see a situation where a substantial proportion of the gay population was infected at that time. It went into the injection drug users and others later on, but a substantial proportion. So if you have a young gay man who might be coming out in his sexuality, he looks around, he sees his friends dying, he sees the hospices full, there's a real major disincentive for risk behavior. Even though some people did practice risk behavior, there's a disincentive. Now, when you have young gay men coming out, you have drugs that you know work, it isn't considered a catastrophic issue in the United States.
So you can live through it.
Right, exactly. And that's bad, because if you talk to anyone who's HIV infected...
And what's the danger of that complacence or that false confidence that you can at worst have a life of drugs rather than no life at all?
Well, the danger is obvious that you have disinhibition. You practice risk behavior that if you were afraid, you unlikely would practice that risk behavior.
Okay, I want to sum up here. Tell people what they should do. Let's get to that part.
Yeah.
I mean, if you had everybody in this room walk out the door now for the next couple of weeks, did what you wanted them to do, to make the phone calls, lobby, talk, get into a program to do something, what would you have them do?
Well, I would have them do just that. I mean, actually, Susan and Chris and Ken alluded to that, is just have advocacy groups to make it very, very clear that for a fraction of a % of the broader budget, you could have a major impact now in turning the disease around, not only in the United States, but globally. So we would be doing what's great not only for our own citizens, but we would assume a place in history, as we have already, as being a major influence on the health of the world.
What has been the impact of the fact that we've changed our views as a country? And probably you and I, I'm a bit older than you actually. The country's changed on the view towards gay orientation.
Right.
More than any other issue I think we've changed on. Don't ask, don't tell is history.
Right.
Probably same-sex is probably going to be, in our lifetime, predominant, maybe state by state, we don't know. DOMA seems to be dying. People in the latest poll, I think it was CBS, 53% support the right of a person to marry a same-sex partner. That is so dramatically different. Now, that information, that acceptance, that more than tolerance, acceptance, how does that work here? Does it have a positive effect about brotherhood and sisterhood with the gay community and the straight community, and therefore caring more about a disease that has in this country affected more in the gay community?
The answer is yes. It has been a much improvement over the last several years, decades as it were. The acceptance, so there's less stigma associated with that. The African American community in the United States, and you'll hear, I'm sure, from Phil Wilson about that, are still in a situation where the stigma associated with being an African American gay man is
it's true
much
among Hispanics too,
greater,
well.
and Hispanics also. And that's something that he and the people that he works with are working on very, very intensively to help remove that stigma so that we can get the same sort of community support and reinforcement for low risk or no risk behavior.
You're my hero, Tony.
You too, kid.
Thanks a lot. Thank you very much.